Good morning. Welcome. Good morning. Welcome to Medical Grand Rounds. I'm very happy this morning to introduce Dr. Allison Ramsey, who most of you know. She's been an allergist immunologist in a Rochester regional practice for almost a decade. Is that correct?
Since 2011.
And her topic today is something they've been getting increasingly involved with in the inpatient setting, penicillin allergy initiatives at RGH and beyond. So, Allison.
Thank you, Dr. FACAAI. Good morning, everybody. Thank you for braving the cold weather and skipping out on your holiday errands to join us at Grand Rounds. Some of you might notice that my title is a little narrower than what was advertised for Grand Rounds. I am a humble allergist, and I have just been mostly involved as part of the team effort for penicillin allergy initiatives at RGH. For the antimicrobial stewardship piece, I'm not the go-to for C. diff or MRSA. Those ladies are sitting in that row right there. So I'm going to go through what some other institutions are doing for penicillin allergy, what we've done here at RGH. I'm happy to take questions, but what everybody should know is that I am one member of a great team, and I'm presenting a lot of work that has been completed by some wonderful people here at RGH. So I'm the messenger showing you what we've done, and credit certainly deserves to be spread around amongst all of those people. So these are my disclosures. I have a research grant with Dr. Mustafa from CSL Behring, not relevant for the talk today. I'm on the Speakers Bureau for asthma, not relevant to the talk today. But I do practice what I preach. I'm not penicillin allergic. But full disclosure, I think my brother has a fake penicillin allergy that I have to bring up this holiday season. So I've spoken to this audience before about penicillin allergy epidemiology and the risks of the label, and I think that's something you're all well versed in. We'll just review for a brief second that information. I'm going to take you through what some of the other institutions are doing, the other institutions in our field who've really been leading the way for how allergists can help with this problem. And then I'm going to take you through some of the initiatives and studies we've done at RGH on both an inpatient and outpatient level, and then take you through some of our current initiatives that I think a lot of you have witnessed. And then, as I said before, I'm happy to take questions. If you have a burning question in the middle of the presentation, I'm happy to be interrupted. I have 3 small children. I'm used to being interrupted. But then we'll save some time for the end as well. So I think during the holiday season, it's really nice to have inspirational quotes. This is a quote from the great boxer Muhammad Ali. And it is, if they can make penicillin out of moldy bread, they can surely make something out of you. So epidemiology, I don't think this is news to anybody in this audience, that 10% of the population reports a penicillin allergy, but less than 1% of the population, when they're evaluated, will truly be allergic. Some of you probably in the hospital setting are like, no, this comes up more often than 10% of the time, and that actually is true. On the inpatient side, it's probably higher, 15 to 20%. I think our data has been around 20% here at RGH. But the important thing to know is this is the most common thing patients tell their healthcare providers, and most of the time it's not true. And why is that important? Well, before we go through why it's important, how does it happen? So our patients aren't supposed to know the difference between an allergy and an intolerance, right? So anything that went wrong when they took penicillin somehow ends up in their allergy field. So if they got nauseous and vomited or had diarrhea, that's not, in most cases, their immune system getting in on the act. That's just an intolerance or an expected side effect of the medication. And the other thing that we see routinely is that penicillin allergic children grow into penicillin allergic adults. And what I mean by that is kids get rashes. And when kids are sick, kids get viral rashes. And a lot of times kids may be on amoxicillin for a viral rash, or for an ear infection accompanied by a rash that's caused by the initial virus, and then it's hard to say, was this penicillin allergy or was this just a rash they were going to get regardless of whether or not they were on an antibiotic. It goes into their allergy field, it's a black hole, and it never gets reevaluated. And if you take nothing else home from this discussion today, those should be reevaluated. And I think we've done a good job here at RGH. And there's a lot of patient and physician misunderstanding that allergy fields should be, the intent of the allergy field is to protect patients, right? So you don't want to, first do no harm. But at the same time, it can be revisited. And I think that's something that's changing in medicine in terms of penicillin allergy. So why does this matter? There's a really rich literature regarding the harms of the penicillin allergy label. And just remember back that most people that claim this label are not allergic. So if you enter the hospital, not you, I don't want that for any of you. If someone enters the hospital with a penicillin allergy label and they are treated with an alternate antibiotic, we know that that set of patients has a higher risk for MRSA, they have a higher risk for VRE, their chances of cure of whatever infection we're treating is lower. They also have an increased rate of infection recurrence. We know that their hospital admission is likely to be longer, which means it's going to be more costly. If their infection doesn't go away or then it comes back, they're more likely to get readmitted. They also are at higher risk for side effects from other antibiotics, like acute kidney injury or C. diff infection. And then a recent study out of sort of a big data analysis has actually shown penicillin allergy, looking at all comers with penicillin allergy, there's an increased rate of mortality. I have to thank my colleague Mary Steiku for this beautiful slide. She's way more talented at slide making than I am. But there are many articles to support these short bulleted statements and why this label is important and should get your attention. So I'm first going to take you through other institutional approaches, mostly from the allergy perspective and how this particular subject has actually gained traction in a field like allergy, where we spend a lot of time in the outpatient setting, but we've realized that this is an important area that we can make an impact and help colleagues on the inpatient side. So this initial study was in the Journal of Allergy and Clinical Immunology and Practice in 2017. And I think this really got everybody's attention that we as allergists should be involved in penicillin allergy and antimicrobial stewardship. UT Southwestern is one of the leading institutions for drug allergy in our field. They actually, at one of their hospitals, got a grant to look at how do you address penicillin allergy in the inpatient setting. And they actually hired a pharmacist based on this grant. And pharmacists in Texas are able to skin test. And that's not the case yet in New York State. But so that's a little bit of a distinction between there and here. But what they did is they had their pharmacists look at their patients every day and look and see who had a penicillin allergy. In this study, they excluded anybody who was on an antihistamine because they were just skin testing these patients, and antihistamines can interfere with skin testing. And then they basically triaged patients based on whether or not they were being discharged, whether or not they were on antibiotics, whether or not they were on carbapenem or monobactam therapy, and then whether or not they had HIV, malignancy, or diabetes, which were higher risk conditions. They also evaluated everybody who had, obviously, who they were requested to consult for. And they screened a little over 1,200 people, and they evaluated 252 people in person. I think it's interesting, 5 of those 252 people were never allergic. So that low-hanging fruit exists, and I would encourage everybody in the audience to recognize it. If somebody says, my sister's allergic, so I don't take penicillin, they're not penicillin allergic. Please remove it from their record. I I, as an allergist, give you permission to hit delete. It's so satisfying. So that low-hanging fruit exists everywhere. Take it out of the record. And then they had some patients where the test wasn't able to be completed due to critical illness or their histamine control was blocked. But they completed tests in 228 people, and only 5 had positive tests. And we know from studies that penicillin skin testing probably overcalls penicillin allergy, so perhaps not all 5 of those were truly allergic, but the odds are high enough that we say continue to avoid it. But 223 people were able to be transitioned to other antibiotics. And so looking at the numbers, look at vancomycin use changed in a very significant manner, as did fluoroquinolones, as did carbapenems, and you can see that penicillin use went up significantly, which is on the far right here. So, you know, as hospital-based practitioners or anybody who sees these patients every day, you know that you don't want someone to have to be on vancomycin if they don't have to be. You don't want someone to be on a fluoroquinolone if they don't have to be. As Trianam is really expensive. And so getting to these penicillin-based antibiotics in the face of this negative testing really makes a huge impact. So then that was the UT Southwestern approach. The other sort of leading institution is Partners Healthcare. So the Harvard Medical System has a really robust drug allergy program, and they've really taken the lead with penicillin allergy as well. And the UT Southwestern approach kind of looked at skin testing all of these people at one hospital. And at Partners, they have 5 different hospitals. And what they did is they instituted a multidisciplinary approach involving allergists, infectious disease doctors, other people with buy-in, nursing leads, pharmacy leads, and they instituted this pathway where they essentially said if you have red flag symptoms, you know, Stevens-Johnson syndrome or toxic epidermal necrolysis or drug fever, you're out of luck. You still have to avoid penicillin. If you have a history that sounds like an IgE-mediated reaction, like anaphylaxis, wheezing, throat swelling, low blood pressure, you should avoid penicillin. We're not going to skin test you, but you're safe to use a cephalosporin, and we're going to do a test dose procedure, which is where they give like 1/10 of the dose, wait 30 minutes, and then give the full dose. And then in minor reactions, like a very minor rash, a maculopapular rash, but no other organ involvement, if the allergy's on the list and the patient's like, I have no idea how it got there, then they say just give a cephalosporin. You can give a test dose of penicillin. You can give a test dose of a 1st or 2nd generation cephalosporin. And they rolled out this protocol to all 5 hospitals, and they also had clinical decision support firing in their electronic medical records. And they also had a phone app and a website where providers could look up, could get clinical decision support on the website or on the app. And then for cephalosporins, they had another pathway that showed potentially doing test doses to cephalosporins with dissimilar side chains, because patients who have a history of a reaction to one cephalosporin may actually tolerate other cephalosporins. So this has been the Partners Healthcare approach. And the reason for this broader approach is that it's not practical to skin test everybody with penicillin allergy. There's just not enough manpower. It's time intensive. Patients often don't want to do it. Sometimes they're on interfering medication. And this is a way to get around that, to kind of spread the tentacles more for delabeling. And then they analyzed what they did. And in this particular publication, their initiative hadn't been ongoing too long. But they tracked how often their best practice advisories were firing in their EMR. They looked at how often people were accessing the clinical decision support website. And then they counted how many test doses were completed and how many people actually went through the full clinical decision support. So this initiative is ongoing at all of those hospitals in Boston. So we are not, as we all know, we're not a ivory tower academic center. But we see a lot of patients. We see a lot of patients with penicillin allergy, and there's not a one-size-fits-all for how you're going to address this problem institution to institution. So I think that our team here at RGH has done a really good job tailoring our resources to our approach. We actually started with a survey of inpatient practitioner knowledge to kind of get an idea of where we were. And we published this in the Annals of Allergy, Asthma, and Immunology in 2017. And Mary Steichel really did the lion's share of the work for this survey, along with one of the residents who's graduated and I think is a rheumatologist now. So we surveyed maybe some of you in the audience, thank you. And then we also looked at Unity inpatient providers, and we included anybody who could order medications. So it was not just medicine, it was medicine, surgery, OBGYN, APPs, MDs, and residents. We also included our pharmacy colleagues, and we did exclude our pediatric colleagues just because of, I forget why we did that, but we did. So we had about a 39% response rate. And here are some of the highlights of what we found. Only 53% of people responding asked how long ago a reaction occurred. And that's important. If you're taking care of an 80-year-old patient and their reaction occurred when they were an infant, that's much more reassuring than if they say, well, yesterday I got a dose of Zosyn and I ended up in the ICU. Only 72% spent 2 minutes or less on a drug allergy history, and I don't think that's bad. I think that's actually fine. I think you can take a good drug allergy history in that amount of time. Only 30% knew that statistic that I flashed up when I began this presentation. Only 30% of people knew that 90% of patients who claim a penicillin allergy will actually tolerate that. This was back in 2000. Well, it was published in 2017, but I think the survey was actually done in 2016. I think we're much better with that now, just based on our initiatives. 25% chose to re-challenge in the case of a severe cutaneous reaction, and those are kind of those red flag symptoms that you're out of luck, you need to leave it alone from then on, like Stevens-Johnson's, like DRESS syndrome, drug fever, acute kidney injury. We can't help you there. Most people don't have that history, but if they do, you have to leave penicillin alone. And then 86% report never consulting allergy immunology or doing so only once a year. And I do think that's changed, and I have a graph to show that. So this is where we started from. That's just the graph showing allergy immunology consultations. So then our next evaluation is how good is our documentation in the electronic chart? And I think we all know we could do better. So this was a project that Mary Steichel and I did along with a pharmacy student from St. John Fisher, where 100 inpatients with a penicillin allergy were identified and surveyed while they were in the hospital. It didn't matter why they were here. And then we compared what they said to what the EMR said. And not surprisingly, I think, probably most people aren't surprised by this, but there's a lot of discrepancy between what patients think and what their EMR says, and probably the truth is somewhere in the middle. So I circled the findings that were the most surprising. So in 19 patients, so 19% of the time, patients described a penicillin allergy that was different from the EMR documentation. 13 patients had a penicillin allergy reaction, but there was nothing in the EMR field. And 32% the patient described a penicillin allergy reaction, but the EMR reaction field was incomplete. And then kind of like what I was alluding to before with the low-hanging fruit, the penicillin allergy reaction was documented as family history without a patient history of an allergic reaction. Those are people that aren't allergic. This is affecting their care. You can just delete it. So with that knowledge, Dr. Steichel and I came up with sort of how we were going to prioritize patients for penicillin allergy evaluations. And we don't have a ton of manpower. We didn't have a fancy grant supporting someone to dedicate to this. So we decided to target the antibiotics that were the most important. So vancomycin, moxifloxacin, linezolid, aztreonam, daptomycin. I might be leaving one out, but you get the idea. So we came up with this algorithm that stratified how we were going to approach these patients. And we had Mary Steiku had a report that was generated from Care Connect every morning of penicillin allergic patients. And then she, as part of her stewardship position, is sort of seeing what antibiotic patients are being treated with and whether or not they would be appropriately transitioned to a beta-lactam. So we prioritized people for skin testing. So anybody with an IgE-mediated reaction were approached for skin testing. Anybody with a rash with no other history were approached for skin testing. We avoided people who had more recent reactions. We're probably not this conservative now. We avoided people with red flag reactions, and then, delabeled people that didn't need to have this label if they just had GI symptoms or if they just had a family history of penicillin allergy. We tracked 50 patients, and some of these were formal consults called by the patient's medical team. Some of these were identified by Mary just as someone who would benefit from this. We tracked our data on 50 patients. This is their demographic information. And what we were able to demonstrate in just 50 patients is that we saved 962 days of second-line antibiotic therapy. I think the vancomycin figure is really powerful, 863 days of vancomycin therapy saved. And you can see the data for aztreonam. That's an expensive drug. It's really driving up hospital costs. Also, our sensitivities in the institution to vancomycin are declining, so it's not as an effective drug as we would hope for. We were able to demonstrate a direct cost savings of $70 per patient, which doesn't sound like much, but this is only 50 patients. So imagine if we're able to do this on a bigger scale. And you can see how antibiotic therapy changed. A is the graph pre-evaluation. Most of these patients were on vancomycin or aztreonam. A few others were on moxi, dapto, and linezolid. And then after we had more than half of the patients on a penicillin-based antibiotic or a cephalosporin. And I think the other thing that's important here is I think our institution at this time, I think we've changed really fast, which is a credit to everybody. But at the time, I think there was a lot of hesitancy to use cephalosporins in penicillin allergic patients. And I think some other initiatives by our infectious disease colleagues have improved that sentiment, because the risk of cross-reactivity between penicillins and cephalosporins is really, really low. And in most cases, not something that we should worry about. So then, compared to the survey I showed you where allergy immunology wasn't getting consulted at all, look at what happened. And I think this speaks to the growing sentiment in our field, in infectious disease, in pharmacy, about how important penicillin allergy evaluations are. And so we demonstrated, just as our allergy consults from 2016 to 2018, we had a greater than 400% increase in consults. And some of this isn't even tracked because some of these patients were folded into those studies I just went through, and were not formal consults. We just approached them as part of our study. So then the question is, how do we spread ourselves around a little bit more? Because we as allergists don't have the volume to, camp out at the hospital all day. It's not like cardiology consults or nephrology consults. We're seeing patients in the office and then generally coming here after or coming here before, which is fine. We're happy to do it. We know it's a great public health and patient service, but we got to work smarter, maybe not harder. So the other thing we looked at was using telemedicine for penicillin allergy skin testing. And RGH is a pretty robust telemedicine program. Cindy Gordon had done a great job setting that up with her team. So we met with her and we were already wired here at the hospital to do this. And essentially, this is like FaceTiming with your patients. So this is me. This is actually a real patient, but we put Alexander Fleming's head on the real patient just in homage to him and also for HIPAA privacy purposes. So what we did here was we had a PA come to the hospital for these consults. Patients were still identified for skin testing based on the criteria I said before. So if there was a consult by their primary team, or if they were on any of those high-risk antibiotics that I mentioned before. And the best thing about telemedicine is that our physician assistant is talking to the patient, presenting the patient to me while I'm, in my office, and we're getting work done kind of in both areas. So these patients are being evaluated in a timely fashion at the hospital, and I'm, stamping out asthma and allergic rhinitis in my clinic. So we surveyed our patients with a Likert scale of how did you think telemedicine, this consult was compared to an in-person consult? And most patients rated it, their overall impression, either good or excellent. Nobody said poor. Most people were agreed or strongly agreed that they were satisfied with their telemedicine encounter. And then when they were asked, would you have preferred to discuss this with the doctor in person? They're like, yeah, we don't really care. They were pleased enough with the telemedicine encounter. So we've definitely, we continue to do telemedicine encounters. We continue to stratify people based on high-risk antibiotic use. Our antimicrobial stewardship team leaves love notes to the teams in the charts, like this patient would be better served by a beta-lactam antibiotic. And we're very proud of that and how we've changed the culture at this hospital. But as these initiatives were going on, we as allergists were sort of like in our field, we're saying probably not everybody needs to be penicillin skin tested, and we think most of these people could just be given penicillin, especially these people with really vague reactions from a really long time ago that just involve their skin. So that was the next step that we took, was incorporating just direct challenges to penicillin in our inpatient evaluations as compared to skin testing everybody. So this is very similar to the algorithm that I showed you before, but what we changed is if the reaction was within a year, we said avoid penicillin, but you could do a test dose procedure to a cephalosporin. We still can't help you if you have a history of a severe adverse reaction. If you've had a severe IgE-mediated reaction, we're still going to skin test you, no matter what the timing is. So if you have angioedema or passing out, or if you were short of breath or you had low blood pressure, we'll still skin test you to penicillin, but you could do a graded challenge to a cephalosporin. If you've tolerated a cephalosporin in the past, then you're good to just have a cephalosporin, obviously. And then if your rash or just your skin symptoms, so people presenting just solely with cutaneous symptoms, if that happened within the past 20 years, we said we'll still skin test you. But then if it was greater than 20 years ago, we're just going to give you a challenge to penicillin. And on the inpatient side, for this challenge to penicillin, we gave 1/100th of the dose, followed by 1/10 of the dose 30 minutes later, followed by the full dose. And if you think about the patients you see in the hospital setting, a lot of them are greater in age, so the chances that you're going to capture a lot of people with a reaction occurring 20 or more years ago is pretty high. You see some 75-year-old male who's admitted with a cellulitis or an osteomyelitis, and the reaction was when they were 5. These are the people that we were recommending graded challenges for. And the rest of the algorithm pretty much stayed the same. So we screened 372 patients with a penicillin allergy. 168 patients weren't candidates, but there was a lot of low-hanging fruit here too. So 31, just based on our review of their chart, just got rid of it. 137 were excluded, mostly because of their clinical scenario, what antibiotic was more appropriate for their therapy. If they were pregnant, they were excluded. If they weren't able to consent to the study, obviously they're going to be excluded. And then patients, we ended up with 204 that either were going to be skin tested or undergo challenge based on their clinical history. This wasn't a randomized trial. And so we ended up skin testing, we ended up skin testing or doing a challenge to 100 total patients. And these are the results. So in the skin testing group, again, these are the people with the more severe reaction history. We had 6 patients that were positive, 44 that were negative. And then in the direct challenge group, there was only 1 patient who did not tolerate the direct challenge, and their symptoms were mild in nature, just a facial flushing, no other systemic symptoms. I think it's important to point out that the direct challenge was done on the floor. Didn't require transfer to a higher level of care. Patients received the graded challenges just in the course of their daily hospital sort of routine. And we were able to demonstrate among both these groups, again, a huge savings in second-line antibiotics. 783 total days saved, including 273 days of vancomycin therapy saved, 100 days of clindamycin therapy saved, and 195 days of cephalosporin therapy saved. So at the same time this was going on, we're also addressing this in the outpatient setting because we know that patients that we see in the outpatient setting are, eventually, if their bad luck prevails, may end up on the inpatient setting. So around the same time we were doing our graded challenges on the inpatient side, we were also looking what we could do for our patients that we're seeing as part of our routine allergy practice. So this was a study that my colleague, Dr. Mustafa, and I did together where we took all comers to our office, no matter why they were showing up. You're coming for asthma, you're going to get asked about your penicillin allergy. If you're coming for hives, we're going to talk about your penicillin allergy. And we offered skin testing to all of these people. So we screened 987 patients, and we found about a little over 15% of our patients that we are seeing in our clinic had penicillin allergy. And then this is why they were coming to our clinic. So some had heard the good word about delabeling and they were showing up for that particular purpose. But then a lot of patients, not surprisingly, showing up for asthma, allergic rhinitis, food allergy. So we offered skin testing to all of these people. And out of 155 patients that would have been candidates, 66% agreed to undergo skin testing, which is a little over 40%. We found 58 of the 66 had negative skin testing. 8 of the 66 had positive skin testing. And this was same day. It wasn't make an appointment and come back in a month and we'll skin test you then, because you get a lot of attrition with that setup. So we did this the same day, and we found it took on average a little over 70 minutes. And then we compared, so this was just 2 doctors saying, hey, I'm seeing you for this condition. What about addressing this condition if you have time? We compared our data to our colleagues in our practice who weren't participating in the same initiative, and we did 66 sort of delabeling in this 3 months time period versus 13 in our colleagues. And then we also tracked why people said no. And most of the time, well, not most, 26% of the time is because they were on medications that would interfere with skin testing. About 16% of people had a time constraint. Some people were scheduled for a direct challenge to penicillin. Most of the time, those are pediatric patients. We've really stopped skin testing most pediatric patients. But I think the most interesting thing was that it really isn't because patients are afraid of our needles. That was only 7.4%. And so then we still had this sentiment, as I mentioned, on the inpatient side, that skin testing probably doesn't need to be done for these mild cases. And skin testing probably overcalls penicillin allergy. So what Dr. Mustafa and I did next was took all the patients coming through our clinic, same approach, offering penicillin evaluations to anybody regardless of why they are presenting. But then we randomized people with cutaneous only symptoms. So people who had a rash or hives or itching, anything just their skin, excluding angioedema. And we randomized to be skin tested or to just undergo a direct challenge in our office. And we just generated a randomization sheet from Excel. And these were patients greater than 5 years of age or, children and adults greater than 5 years of age. So we ended up, this is kind of our flow sheet, but we ended up skin testing 80 patients with just skin symptoms and doing a direct challenge to 79 patients with just skin symptoms. And for the skin test group, we found that 10 of the 80 were positive, and only in the direct challenge group, only 3 of the 79 were positive. So our hypothesis here is we know our negative predictive value for penicillin skin testing is good, meaning if your test is negative, your chance of having a reaction is really, really low. But the positive predictive value probably isn't as good. So it's probably about 50-50. So we found we were able to delabel more people in this low-risk group with a direct challenge. And by the way, it takes a little less time and it costs less. So we're really proud of this trial because it has moved our field forward in that there's not enough allergists to do skin testing. It's been our domain, and I think some institutions have spread out who's doing the skin testing, whether it's a pharmacist or infectious disease physician. But I think this trial shows, and also our inpatient data show, that you don't need skin testing for everybody, and you should save it for the more severe people. So then we're still confronted with lots of penicillin allergy, less manpower than you would like. Even with direct challenges, there's still people, with direct challenges, there's sort of probably a way to work smarter now that we know direct challenges are safe in this subset of patients. So we looked at providing e-consultation, which is more formal than what we're all used to as a curbside consult. So this is different from calling up your friend and being like, what would you do? I won't write your name, but what do you think? You can write our name with an e-consult. It's a discussion with the primary team about what question they're asking. The allergist can review the patient's records and then make recommendations or provide an inpatient consult if needed. So we are piloting this on the inpatient side, and I just want to take you through the data about how this came to be and then show you what we've done here at RGH, and that's ongoing. So Partners Healthcare, which is the same institution that I showed you that has the algorithm amongst all 5 of their hospitals, they piloted e-consults in the outpatient setting because they had such a backlog of patients waiting to be seen. So they rolled this out to their outpatient colleagues and said, you can request an e-consult if you're not sure if this patient should be seen. We'll take a look, and if they do need to be seen, we'll tell you that they do, and if they don't, we'll make some recommendations in the chart without directly evaluating or talking to the patient. So they had 321 e-consults requested. They completed 306 out of the 321. This box over here says why they were declined or excluded. In about 26% of the evaluations, they just gave advice or education, and that's all that was needed, and everybody was happy. In an additional 13%, they made diagnostic, therapeutic, or referral recommendations, and then they tracked whether or not those recommendations were followed. And then about 60%, they said, yeah, send them to us. We should see them in person, which is appropriate. This is again, the outpatient setting. But what was interesting here and what got our attention, our team's attention, is that the number one reason for an electronic consult was an adverse drug reaction. So they did 65.7% of the total e-consults were drug reactions. And this is a list of all the drugs that came up for questioning in this pilot program. And not surprisingly, I circled over here, almost 61% of the e-consults requested were for penicillin allergy. So looking at this data, we're like, hey, maybe we could do this at RGH, especially since we know that we've shown that these test doses or graded challenges on the floor are accepted and safe. Patients don't necessarily need me to tell them that. So we started a pilot project with e-consults on October 1st. This data is a few weeks old, so we've done even more e-consults since then, but we're essentially taking every consult that comes to our allergy, immunology, and also rheumatology service and evaluating whether or not this is something that can have advice or if it needs to be evaluated in person. So from the allergy, immunology perspective only, we've done 20 e-consults. We have boots on the ground in our pharmacy colleagues just to confirm that the patient's history is just a cutaneous only reaction to penicillin. But we've done 20 e-consults, 15 of which resulted in penicillin challenges on the floor that facilitated transitioning these patients to a penicillin-based antibiotic. And then, there's still the patients that need to be skin tested, and we come in and do the skin testing for that. Sometimes it's us coming in, and sometimes it's our physician assistant and using telemedicine. And then for the hospitalists in the audience, you may have been surveyed, or some of the APPs in the audience, was this okay with you? Were you satisfied? And overall, we've had positive feedback on a 5-point Likert scale, most responses being a 4 or 5. And so I think this is a nice way to expand our reach. And again, working smarter, not harder, in that I don't need to come for a patient to be like, I don't remember what my penicillin reaction was, when I know I'm just going to say we should do a graded challenge on the floor. So we're trying to save our skin testing and save our resources for the patients that have the more severe histories that should be evaluated in person. I did put this in. I'm by no means an expert on billing, finances, anything to do with any money things, but you can actually bill for an e-consult. And so these are the codes that our friends in billing gave us. It's not a moneymaker, but time is money for everybody involved in medicine. And so this is an efficient way to provide care to patients without, travel if it's not necessary. So then the last thing I want to go over in the last few minutes, and I'll leave room for questions as well, is what about our pregnant patients? So penicillin allergy also is an issue in pregnancy. And this was a big data grab from Kaiser Permanente, and where they looked at pregnant women with a penicillin allergy and pregnant women without a penicillin allergy. And the numbers here are huge because they have this huge database. So they had over 185,000 patients without penicillin allergy and over 16,000 patients or deliveries without or with penicillin allergy. And they found a higher rate of C-sections in their patients with penicillin allergy. They found that the penicillin allergic pregnant women had a higher number of days in the hospital. And they had more antibiotic exposure and more total antibiotic courses. And they found the same things held true looking at penicillin allergy and whether or not they were colonized with group B strep. So more C-sections, they were in the hospital longer, they had more antibiotic courses. So we were contacted by Dr. Grace, who's the head of OBGYN. The OBGYN guidelines changed fairly recently to prioritize evaluating penicillin allergy in pregnant patients. And there is some data for skin testing for penicillin in pregnancy, again out of Kaiser Permanente, where they demonstrated in kind of a proof of concept in 56 study participants that penicillin skin testing was safe. The majority of their patients, 53, had negative skin testing, and 3 had positive skin testing, but this allowed these patients to be treated with prophylactic antibiotics if indicated during delivery. So we are also addressing that in our system where we tell our colleagues in OBGYN to just give penicillin for these instances where there might be penicillin allergy on the electronic chart that shouldn't be there, so family history or intolerance, headache, vaginitis from a yeast infection. We are still saying to avoid penicillin with any red flag symptoms. And then if the patients don't know or they have any other symptoms with penicillin that are worth testing for, we say send them to us. And we've set up kind of a direct referral pathway where pregnant patients can be seen in a timely fashion. So if they need penicillin during delivery, they can get it. And I will say in this population, we do not do challenges. It's probably safe, but no one wants to take a chance, obviously, with a pregnant woman. So we are skin testing all of these patients on the outpatient setting. The nature of the referral base is it's a fairly underserved population, so it might be hard for them to get to our clinics. And if that's the case, we're tracking them, and we're going to try and catch them post-delivery in case this would help them for future deliveries or future health care. So we're anticipating evaluating people that who were referred but didn't show up at our clinic or never made an appointment. We're anticipating evaluating them once they're in the hospital for delivery. So this, as I said, I'm the messenger. We've had a great team here. I see ML Brundage's face in the audience, and her name isn't on here. That's my oversight. ML has also been very helpful with this initiative, but this has really been a team effort, and I think we've done great things for our not only our patients, but also for public health, because we aren't coming up with a lot of new antibiotics, so we gotta use the ones we have wisely. That's my dog. He's also my team. He sits by me while we do this work, so put him on there. So I'm happy to take any questions. We have about 10 minutes. Or if you have some Amazon shopping to do, I can give you some recommendations too. But thank you.
You said the direct saving per patient is about 70. That's just the saving on the antibiotic. There's probably indirect savings that far exceed that.
That's correct. So, right. I'm glad you brought that up. The question is, on our one analysis, the direct savings was $70 per patient. That was just direct antibiotic cost. We weren't smart enough. Well, maybe we're still not smart enough at that time, or we weren't smart enough at that time, and I'm probably still not smart enough to do the indirect analysis. But you're absolutely right that there's savings involved in, future avoidance of X, Y, or Z antibiotic. It's hard to quantify if you avoided a hospital readmission. We also didn't incorporate monitoring costs that you need for the patients who are on vancomycin, trough monitoring, or if they needed a PICC line. So that's the worst news scenario. Like, that is the most conservative estimate, is just direct antibiotic costs, and the savings is significantly much more. And I think that it's powerful that was only in 50 patients.
Fantastic presentation. I was kind of trying to understand, compared to other systems, if you had a sense, are we really grossly over-applying penicillin allergy? Is this something we really need to look at, or do we not have a sense of how many are out there? So it looks like about 20% of the time.
So that's a good question. So you're asking if we as an institution are overstating it? Are we doing something wrong? Absolutely not. I actually think we should be proud as an institution that we have so many initiatives addressing it. So at the beginning, you might have come in a little bit later. At the beginning, it's in all comers, it's about 10%. So in the whole US population, it's about 10%. But on the hospital side of things, it can be upwards of 20%. And comparing us to other institutions, we are way ahead of the curve. So this is something that's come up over the past 5 years or so as a big push in our field in infectious disease and in pharmacy. And I think what we've put in place already, especially for an institution of our size, we have a lot to be proud of, but there's always more that we can do. Any other questions? All right, well, thank you for your time and attention, and happy holidays.